Good morning, and thank you for joining us for the sixth and final webinar in our series, Intense International Teaching for ENT Surgeons. My name is Aurelian Geru. I'm the co-course director with Dr. Naren Solman from the First Central Hospital of Mongolia. So we have delivered 6 webinars on 6 different topics. Just to remind you of the webinar structure, the first part describes the UK patient journey of a patient with atopic pathology. Today we have pediatric airway management. The second part for the webinar, we encourage you to fill out the reflection and evaluation form, and on completion you get a certificate of attendance. So please write your questions in the Zoom chat and we will get to them at the end of the first part of the webinar. So it gives me great pleasure to introduce our panelists, Mr. Pedef, Ms. Stevenson, Ms. Timms. Thank you very much for joining us.
Good morning from England. It's our pleasure to be with you this morning. It's at 8 o'clock in the morning here, so we're all up fairly bright and early. My name's Kate Stevenson, and I'm a paediatric ear, nose and throat, head and neck surgeon. I've worked in the UK and in South Africa. I'm a specialist in both countries, and we've got a really interesting topic for you today. I think a very important topic, and I hope it's very useful. So along with me in the panel, we've got Sarah Timms. She's not with me in Birmingham. She's about 2 hours north in a place called Manchester, and she's a senior doctor in training, what we call a registrar or a resident. And she's got interest both in paediatric ear, nose and throat surgery and in global health. And then Khilaf Peled on the right there, he's a doctor that's trained both in Hungary and in Israel. He's a qualified ear, nose and throat specialist with a particular interest in paediatric ENT. So from this little island in the Northern Hemisphere, we're coming a long way to you. But as you can see on the map on the right there, we're both of our centres are based in the middle of England. This is where I work, to give you an idea. We've got very old parts to the hospital, built in 1862, and very new parts of the hospital. This is where we operate, in this beautiful blue building on the right. And it's a very busy centre, just a children's hospital, seeing more than 600,000 patients a year. So the format for today, we're going to have a case-based discussion to start with, but because paediatric airway management is so broad, we didn't want to focus on just one pathology. So we'll then go on to generally talk about the non-surgical management and the surgical management of the paediatric airway. So it's my pleasure to hand over to Sarah at this point.
Thanks, Kate. Hello, everyone. Lovely to be with you today, and thanks for joining the webinar. So I'm going to start by presenting a case, and then we'll follow on the discussion from there. So this is a 7-week-old baby boy who presents to you with stridor. He was born at 39 weeks gestation and had a 2-day admission at birth, requiring some oxygen, but he wasn't intubated, and then he was discharged. In the last few weeks, his feeding has been worsening, and his parents describe this squeaky breathing, which becomes worse when he's crying. He hasn't got any other history, and he was born by a vaginal delivery, and there were no complications during pregnancy. So on examination, we've got a video of what he might look and sound like. Have you got the sound with that, Kate? Oh, you can hear it. Just about. Okay. You can see that this little boy is working very hard to breathe. He's got a tracheal tug, and there's recession subcostally and intercostally. I don't know if you could hear it very well, but he had a high-pitched inspiratory breathing noise. Yeah. Thanks. Yeah, can you hear that? Raised respiratory rate, but normal saturations on air. Thanks. So in the UK, we perform a flexible nasendoscopy, and here's a video which doesn't have any sound of what you see when you're examining the larynx. So we see a very limited airway. The epiglottis is almost completely curled over, and posteriorly we see the arytenoid cartilage is collapsing into the airway on every inspiration. Thank you. So now just to talk a bit more broadly about noisy breathing in children, we tend to describe it in terms of the level of the obstruction. The examination findings can often help to identify that. So you can see that if there's an airway obstruction that's affecting the pharynx, then we usually get a stertor, which sounds like a snoring breathing, it can affect the voice to be slightly muffled. It usually doesn't involve a cough. In the supraglottis or the glottis, tend to get an inspiratory stridor, and that can affect the voice for obvious reasons. The glottis is involved, so you'll often get a hoarse voice or cry. In the subglottis, the stridor is often biphasic, and in the lower trachea, it's an expiratory noise. Thank you. So there are hundreds of causes of airway obstruction, as we can see from this table, which I think just emphasizes the need to take a good history, because the history is often the key indicator as to helping you to narrow down this enormous list. What I would just point out is that subglottic stenosis can be congenital or acquired, and when it's acquired, it's following intubation. And also to see that on the acquired side of the chart, a foreign body can present in any level of the airway, and it will present differently depending on where it's located. On the right side of this slide, we've just got a diagram representing the cross-sectional area of the airway in a child and in an adult. And you can see that in the child, the cricoid area is the narrowest. And you can also see in general that that airway is much more prone to obstruction for several reasons. If you just click Kate, we've got the fact that children's occiput is larger, so their head and the top of the airway tends to be tilted forward, which can tend towards compression. They also have a larger tongue and larger arytenoid, so again, it doesn't take a significant amount of swelling to impinge on the airway, and we saw that curled epiglottis shape, which again is prone to obstruction. So if you're seeing a child with stridor or airway obstruction, these are some important points to take from the history. The stridor itself, the noise, the breathing noise, how did it start and has it progressed? That will give you a clue if it's a very sudden, acute emergency presentation, or if it's a more chronic. In terms of the perinatal history, it's important to know whether the child has ever been intubated because of subglottic stenosis, whether their delivery involved any instrumentation, because that can cause a vocal cord palsy. The pattern of the stridor, so laryngomalacia is worse when crying and feeding, and pharyngeal obstruction, so things that are causing a stertor, will be more pronounced when sleeping. Other features that you need to ask about: have the child had any episodes of apnea or cyanosis, which might suggest a non-airway cause of the breathing problem? Have they got a cough, and have they got respiratory distress? And in all children, it's important to ask about feeding, their pattern of growth, and then if they've had any aspiration, so chest infections, which might point you towards certain pathologies such as vocal cord palsy, tracheoesophageal fistula, neuromuscular disease, or a laryngeal cleft, and a general medical surgical history. Moving on to examination, we're always going to start with observing the child, and we can learn an awful lot, as we've seen from those videos already, just from looking. In the UK, our patients or our parents will often bring us videos taken on a mobile phone of a particularly bad episode the child might have had, or a video of the child asleep, which is very, very helpful. And whilst we're observing, we're listening to any noise that the breathing is producing. We're characterizing it as inspiratory or expiratory, and the quality, high-pitched, hoarse, harsh noise, etc. If we're concerned that the airway is unstable, particularly in the case of suspected epiglottitis, we don't want to cause any further distress to the child. So we need to be very careful about whether we instrument or examine the airway at all. And then, as we saw with that first video, we're looking at work of breathing. So what is the child doing to enable them to breathe? Is there recession, suggesting that there's difficulty drawing in air? And the recession can be subcostal, intercostal, suprasternal. And if you see the sternum itself recessing, that's a really significant sign of work of breathing. And then other things like nasal flaring and head bobbing. And in this little boy, this photo on the right, you see his posture is leaning forward to try to maximize the diameter of his airway. Then we're going to perform some kind of laryngoscopy to examine the airway directly. In the UK, we have a choice between flexible laryngoscopy and direct laryngoscopy. Flexible laryngoscopy uses this device that you see on the bottom right, which is a fiber optic camera. It's done while the child is awake. And so the benefit is that you can see the airway as the child is breathing or crying, and there's no anesthetic required. On the other hand, the child may be quite non-compliant with allowing this to be passed through the nose. So we would still consider the gold standard to be direct laryngoscopy, which my colleagues are going to talk more about this morning. And it also has the benefit that therapeutic procedures can be performed at the same time. Imaging is not so primary in these cases, but there may be some value for it. For example, in a case of a suspected foreign body, a chest X-ray will be performed. And if there's a concern about vascular compression of the airway, such as abnormal great arteries, then a CT will be performed, but that will usually be done after the laryngoscopy has shown the airway, the tracheomalacia or bronchomalacia. Thank you. I'll pass over to Mr. Peled now.
Hi. In the next few minutes or so, I would like to talk about the management of children with an acute upper airway obstruction. As was mentioned by Ms. Stevenson previously, it is a wide area and it really depends on the underlying pathology. And so we'd just like to share with you our thought process and our capabilities. And we do need to take into account that there is a wide variation around the world in regards to the management of an acute upper airway. And I'm just talking about my experience from Israel and from the UK in the management of these children. So when we are planning a treatment for a child with a suspected acute upper airway obstruction, there are certain considerations which are quite crucial for us to know. Initially, I would like to know what is the team that I'm going to work with, where an ideal team includes a pediatric ENT surgeon, a pediatric anesthesiologist, an experienced theater team, and a pediatric intensive care unit and team that can help us. The next thing that I would like to understand is I would like to have some notion as to what I think the problem is. And that is a key feature that will help me to understand what I'm facing. We do understand that there is a difference between a single obstruction, a single anatomical level obstruction, for example, a child with bilateral vocal cord palsy, versus a child with Pierre-Robin syndrome and a known subglottic stenosis, and the approach could be quite different. The second thing that I would like to know in regards to the problem is whether or not what I'm seeing at the moment, is it a static condition or is it an ongoing, dynamic, deteriorating condition, in which case timing could be quite crucial. Now, once I know what is the team that I'm working with and what I think the problem is, then I can start understanding or thinking what is the best procedure for this patient. And probably the most important thing is, how do I expect this to progress? Which is important for us when we prepare everything and talk to the team, as I will discuss in a few minutes. So I have divided the approach into different parameters, as you can see here. Before we will start and talk about each and every one of them, I just want to emphasize that these are not mutually exclusive. And you do not necessarily need to go in a stepwise fashion. Once again, it depends on the child, it depends on the pathology, and it depends on the severity of the case. So from a conservative point of view, all the children with an increased work of breathing or a suspected acute upper airway obstruction, I would like them to be connected to a monitor, and I would like to have their ABCs continuously measured, especially saturation, heart rate, and respiratory rate. Depending on the child, especially the neonates, some of them might respond very well to positioning. This is especially true with children who are obstructed in a tongue of base level and children with severe laryngomalacia, where lateral positioning can sometimes help the children and improve their breathing. All children who desaturate will require oxygen, and this might be delivered either via prong or mask or a dome, depending on the child and the facilities, the capabilities the facility have. And medications that we regularly use for an upper airway obstruction includes steroids. Here in the UK, we use dexamethasone, usually 0.2 milligram per kilogram 3 times a day. And we can also use on top of that some adrenaline nebulizer that may help the child. I just want to stop for a second and talk about the usage of nasopharyngeal airway. This is something that I encountered mostly here in the UK. We do not use it regularly in Israel. Nasopharyngeal airway is basically a tube which is inserted through the nose, and the tip of the NPA is ideally situated in the hypopharynx. It is a very good way to bypass an obstruction which originates at the level of the nose, the oral cavity, and the base of tongue. Depending on when the NPA is introduced, it could be used for long term, and in selected cases, it could avoid a tracheostomy. We use it quite regularly here at the Birmingham Children's Hospital among children with Pierre-Robin syndrome who are obstructed on a base of tongue level. Now, should the conservative management is not sufficient and the child is still working quite hard and deteriorating, we may use non-invasive ventilation. Non-invasive ventilation is a means through which we can administer ventilator support through a mask. This is usually managed by the intensive care unit team here in the UK. The main benefit of non-invasive ventilation is that it provides pressure support to the child, and especially it provides a PEEP, which is a positive end expiratory pressure. And what it does is that it maintains the patency of the upper airway, and it may help the child quite a lot. Depending on the child's age, it can be used either via nasal prong or a nasal mask or a facial mask. And once again, usually the pediatric ENT team are the ones who manage non-invasive ventilation. Now, before we head on to the possible ways through which we can intubate the child, there are 3 key features which I think are very important for us to understand
when we are heading down the intubation route in a child with an acute progressive upper airway obstruction. Initially, all invasive airway procedures, all invasive airway procedures on children with an ongoing upper airway obstruction should be done in theater if possible. The second thing is, which is very important, is because we do not really know how the intubation is gonna proceed, we want all of our tools and all of our armamentarium ready and prepared before we start the procedure. So, for example, if there is a child with a Pierre-Robin syndrome or a child with a subglottic stenosis, I would like all the different types of laryngoscope, the video laryngoscope, the rigid bronchoscope, the flexible bronchoscope, and any kind of instrument that may help me in the intubation process to be ready and prepared at the time we start the initial intubation. And the last thing, which is probably the most important one, is that team brief and communication is absolutely crucial for optimal management of a child with upper airway obstruction. This is especially important between the ENT surgeon and the pediatric anesthesiologist. And I would like to operate in an area where all the team is fully aware as to what we are doing and what is the next step that we're going to use should this not succeed. So just for us to understand, I have divided the different means for us to intubate into different categories. Once again, it really depends on the child. These are not mutually exclusive, and you do not necessarily need to go in an ordinary fashion. You really need to evaluate the situation, evaluate the child, and then try and use the instrument that you think has the highest chance for a successful intubation. As a first step, we may use the traditional laryngoscopes. We can either use the Miller or the Macintosh. Here in the UK, usually this is done by the pediatric anesthesiologist. And if this is not successful, we can try and use a glidoscope that you can see here on the right upper picture. The glidoscope basically have two benefits in comparison to the traditional laryngoscope. Initially, it has a screen. So basically a glidoscope or a video laryngoscope is a laryngoscope which is connected to a screen. It will allow the rest of the team and the pediatric ENT surgeon to have a look at the upper airway and to assess the airway difficulty, which is important for decision-making as we proceed with the intubation. And the second thing, which is good with the glidoscope, is that the blade of the glidoscope is just a little bit more curved, and that allows us just a little bit more anteriorly. We may push the base of tongue just a little bit more anteriorly in order to have a good visualization of the upper airway. Sometimes we may face a situation where we can see the arytenoids and the epiglottis, but we do not see the entire length of the vocal cords. And so we may see, for example, just the posterior aspect of the vocal cords, in which case we can try and intubate the child through the use of different guides. The classical one that we are using is called a bougie. You can see it in the lower picture. I'm sorry. And what we do is that we just introduce this guide through the upper airway. And on top of that, we can slide the endotracheal tube. If the laryngoscope and the video laryngoscope is not successful, we can then continue and try and intubate the child using a rigid bronchoscope. Or a rigid bronchoscopy or a laryngotracheal bronchoscopy is a procedure that allows us to have direct visualization of the larynx and the upper airway. In an intubation setting, what we do is we use a 0-degree Hopkins rod, as you can see in the upper picture. And on top of that, we can slide the endotracheal tube. And what we do is that we just introduce the Hopkins rod through the vocal cords, and we just slide the endotracheal tube. In severe cases, where we find it difficulty to ventilate the child, we may also use a ventilation bronchoscope that you can see here in the lower picture. The ventilating bronchoscope has a pore for anesthetics, for the anesthesiologist to connect into the ventilating bronchoscope, and it's got some pores on the distal end of it through which we can ventilate the child. So you can see here the red dot that Ms. Stevenson is helping me, showing us the ventilating pores and the connection to the anesthetics. This is a picture that shows how exactly it looks in theater. What we see is the child is situated in a supine position where the head is a little bit extended. With our left hand, we are holding the laryngoscope, and with the right hand, we're holding the endoscope, and we're getting a direct visualization of the upper airway. We'll just introduce the Hopkins rod through the vocal cords, and we will just slide in the endotracheal tube in order to intubate the child. So, although rigid bronchoscope is a very good way to intubate the child, sometimes because of several underlying pathologies, it could be quite challenging to have a good visualization of the upper airway. And here you have two pictures. On the left-hand side, the upper pictures show you a good visualization of the upper airway. We can see the epiglottis, we can see the arytenoids and the vocal cords, and it will be quite easy to intubate the child. Unfortunately, the lower picture on the right-hand side, you can see that although we see the epiglottis and the arytenoids, we are not fully available to visualize the vocal cords, and so it could be quite challenging to intubate the child using a rigid bronchoscope. In case we are having difficulties using a rigid bronchoscope, the next possible tool that we have is using a flexible bronchoscope. And here is an example of a child that has a tongue base obstruction. In the upper picture, you can see that the tongue base is basically occluding the supraglottis and pushes the epiglottis posteriorly. And so with a direct visualization, although we can see the supraglottis, it's quite easy to understand that we cannot intubate the child. We can try and use a flexible bronchoscope, and you can see the result on the lower picture, and that just might give us just enough room in order to see the vocal cords and intubate the child. Once again, what we do is that we pass the endotracheal tube alongside, on top of the bronchoscope, and we reach the vocal cords, we pass the vocal cords, and then we just slide in the endotracheal tube. That's it, and I will allow Ms. Stevenson to continue from here. Thank you very much.
Fantastic. Okay, so we've started with a case of severe laryngomalacia, and obviously we've identified the problem, but we need to treat it. And we also now have an idea of the range of airway pathologies and the steps we can take before we get to picking up a scalpel. So there's different ways to secure the airway. And for surgery, we have two main roles. Either we're making the airway safe, we're literally life-saving, and that's with access to the front of neck, which typically to ear, nose and throat surgeons is a tracheostomy. Access through the cricothyroid membrane is more here to do with anesthetic staff, with emergency staff, and those that are not trained to do a tracheostomy, because a tracheostomy in the right hands can be quite quick. But if you don't have that option, going through the cricothyroid membrane in the over 12s is definitely the quickest way to access the airway and to buy time. So we're either saving the life, making the airway safe, going below the problem, or we're trying to treat the problem itself. And of course, that's completely tailored management. It depends what the problem is. So I'd like to go through a little bit of the range of these surgeries, not just tracheostomy, but what we can do surgically to make a problem better, including the laryngomalacia case that we've seen already. So first on to tracheostomy. The surgery itself may be the simplest part, actually. What's so important is what happens before and after in terms of the care of this child with a tracheostomy. And the younger the child is, often the more critical the concerns. So just with securing the airway, having an experienced anaesthetist for the time of tracheostomy is really important. Ideally, when we're doing a tracheostomy, we'd like the child to be intubated, but in some circumstances that just isn't possible because of an airway pathology. So they might be just holding a mask to ventilate the child for the procedure, still a general anesthetic, or they might be using a laryngeal mask airway. So not a tube passed through the cords, but something that sits above the vocal cords to provide ventilation. And sometimes we can even do a tracheostomy with a rigid bronchoscope in place that's ventilating the patients. But it's much better to have a tube or a bronchoscope in the trachea so you can feel it better in the midline. Positioning is really important for a children's tracheostomy. So we're used to extending the neck for a tracheostomy, but in a child, it's different anatomy. The occiput is bigger, and therefore you need to really get them into a more than a neutral position. But also if you hyperextend the neck, if you overextend the neck, you'll end up potentially going too low in the trachea because it's pulled up too much. Okay, so often it's a bag under the shoulders, as you see here, or a pad under the shoulders, something to secure the head and make sure the child is sitting very straight, head, shoulders, body, all very straight to avoid rotation, and a strap under the chin. Some tape which goes to the operating table is often very useful as well, particularly in the infant. I'd like to go through the steps of a pediatric tracheostomy briefly. Okay. I would prefer to do this with magnification, and this isn't a procedure that lends itself to using an operating microscope. You're moving around. So if you have surgical loops, as you see here with the glasses, that's really useful in terms of getting better magnification, seeing the anatomy, and staying on track. The incision needs to be between the cricoid and the sternal notch. We want to approach the trachea about the second or the third tracheal ring. We want to be avoiding the first tracheal ring and the cricoid. So our incision of the skin is to go about at the right level, but then as we go inside to make sure we found that level. So it can be a horizontal or a vertical incision. There's no one way to do it. And then you dissect in the midline, step by step, hemostasis in each step onto the trachea, checking that you're in the midline. And you do that by feeling either with your finger or by using a little instrument like a curved hemostat, what we'd call a mosquito. As you go down, as you can see in the picture here, the strap muscles are separated in the midline, gently retracted. If you encounter the thyroidismus in a child, that does probably need to be divided so it doesn't get in the way now or later. And in a very little one, you can just use bipolar diathermy to go through that in our practice. There are many differences between a child's and an adult's tracheostomy, and the way that we secure the airway and the way that we form the stoma are different. So in our practice, we place these things called stay sutures. These are the blue sutures you can see in the image. These are going either side of the tracheal opening that's going to be made. And they're for safety, particularly in the first post-operative week. When you make the incision, those sutures can help you open it and then assist when you're inserting the new tracheostomy tube. Also, if the tracheostomy tube came out in the first week, you could use them to bring the trachea to the surface to show you where you need to go and to open up that incision. See, it tends to be a vertical incision. We're not cutting a window out, and we want to preserve as much cartilage as possible. And this can be done, hopefully, apart from in a very emergency situation, this can be done very slowly and very carefully. So once the trachea is opened, we can insert the tracheostomy tube. This is an example of one of the tubes we might use that's designed for children. And we want to make sure that this new tracheostoma heals quickly and becomes stable as quickly as possible. So we place something called maturation sutures, indicated in the bottom picture by the white arrows. And these are absorbable stitches that there are usually 4 to 6 of them that take the skin down onto the trachea. So you get a nice surface to heal together, a quicker healing wound. It also makes the hole more stable and it holds it open. So these are stitches that aren't removed, okay? Whereas the blue stay sutures, those are not absorbable. Those are taken out usually after a week after the first tracheostomy tube change. And once you've placed the tracheostomy tube into the neck, they can connect it to the anesthetic tubing, make sure it's looking all right in the right place, ventilating well, then you can take any tube out of the top end. This slide just shows you a little bit more, I hope, as a useful diagram about the different sutures. I'll highlight here. So there's the tracheal opening. We've got bottom of the thyroid cartilage, probably bottom of the cricoid cartilage, first tracheal ring. So this is an incision to the second and third tracheal rings. Here's the stay sutures that are retracting, and then the maturation sutures placed. And these stay sutures can be taped down to the chest with clear marking saying it's the left and the right, not to be confused, and don't remove them until the first tube change as arranged by the ear, nose and throat surgeon, ideally who did the procedure. Okay. So you can look in many textbooks and online resources about the complications of pediatric tracheostomy. There are many, okay, but there are great benefits to it. Okay. It sometimes can be absolutely the best option for a child. So to summarize very briefly about pediatric tracheostomy, the positioning is key. We have certainly safety measures in how the tracheostomy is done and how the stoma is formed, and the aftercare is really important. And we can talk about that a little bit more in the discussion if you'd like. So we've talked about securing the airway in different steps, including a tracheostomy. But now let's talk about treating the problem, okay? And again, this is very much tailored management to fit the problem. And it could be an endoscopic surgery, could be an open surgery, or there are some that actually benefit from having both approaches at the same time. Of course, we've identified the problem by looking at the airway. And of course, we've got to know what's normal. These are pictures taken from a study that we would do, looking at all levels of the airway, from the glottis, through the cords to the subglottis, down the trachea to the carina. So we do a full assessment to make sure we know what the pathology is and how many pathologies there are. Bear with me a second. So coming back to our case, this is the endoscopic view of an infant who has significant laryngomalacia. You can see the very crowded supraglottis with the posterior collapse. But when you get to the cords and further down, that's normal. And we can get some beautiful images of the upper airway. We want to position the child in what we call suspension laryngoscopy. That means that you've got 2 free hands to work. And we tend to use an operating microscope for this procedure, so that you're using the microscope rather than a rigid endoscope or Hopkins rod to visualize. And we want to go from the picture on the left to something like the picture on the right, where the larynx is opened up and we've debulked that mucosa at the back. So the 2 steps to an aripiglottoplasty, otherwise known as a supraglottoplasty, is dividing the aripiglotic folds, what you see here with the green lines, and then debulking any redundant extra mucosa that's on top of the arytenoids, including the cuniculate and the cuneiform cartilages, if applicable. And this varies from child to child. It can be done with cold steel instruments. Some places use a laser for this. However, that isn't our practice. We don't find it sufficiently useful, and it has its other concerns. This video shows how we would divide the aripiglotic folds. So you can see the suspension laryngoscopy using a straight cupped forceps to hold the arytenoid, put it under tension, and then some curved scissors there are cutting the right aripiglotic fold. It's a very small surgery that can make a big difference, and its outcomes are most predictable in otherwise normal children. You can see a white, what we call a patty. That's a little swab that has an attaching string, and that's probably got some adrenaline on it to limit any bleeding. But so far, this procedure's been nice and dry and bloodless. Okay. So that's the first step of dividing.
2 minutes left, if that's okay.
I'm sorry?
We have about 1 to 2 minutes left, if that's okay, before we...
Yeah, we're getting there nicely, thank you. Okay. So there's dividing that fold. Okay. The second step, if applicable, would be to debulk at the back. Okay. Here's another case of endoscopic surgery where there's a cyst, as you can see on the left, and that's actually behind the base of tongue in the vallecula. So you can't even see the larynx, you can't see the epiglottis. And this baby presented with symptoms like laryngomalacia. This was operated on endoscopically, and you can see when the top of the cyst has been taken away, we've resolved the problem, we can now see the larynx, and the baby will be a lot better in terms of airway and feeding. We often see and treat subglottic cysts, and this is particularly in children that have been born early, that have been intubated, and they can slowly grow and obstruct the airway. We would use endoscopic surgery to treat these, taking off the top of them, and then we can use something called a balloon dilatation to help crush any granulations and improve the airway, particularly if there's a soft or fresh stenosis. The balloons that we can use are often used in cardiac and endovascular surgery, although there are specific airway balloons as well. And I've got a video to show you of that. Here's the balloon being inserted under direct vision. This works very well because it pushes outwards, giving radial force. It's inflated for just a minute or two. And I will fast forward. And then taken out. There we go. So we can see an improvement in that soft stenosis in the subglottis. That was endoscopic surgery. Open airway surgery. Often we don't need to use because we have endoscopic approaches and we're not getting high grades of problems because of good prevention, good anesthetic, and good intensive care techniques when it comes to prolonged intubation. But if you have a high grade narrowing or a high grade pathology, for example, a laryngeal cleft, a congenital pathology, you might need open airway surgery and somewhere where you need to actually expand the framework of the larynx or the trachea. So there's many options, but they include reconstructing around the level of the larynx or in the trachea. And there's even very more advanced surgeries where the trachea is slid on itself, called a slide tracheoplasty, to improve its circumference. So particularly for subglottic stenosis, when you've got a high grade or 3 or 4, this would be open surgery. And on the picture on the right, you can see that the front of the airway has been opened through the upper trachea, through the cricoid here. And you're looking into the airway at the end of the endotracheal tube. A rib graft, a costal cartilage graft, can be harvested and placed in the front of that airway to expand its lumen. And there can be a graft put at the back as well. This can be done in one stage, avoiding a tracheostomy. but you need an intensive care unit to look after that child intubated for a while, or in 2 stages when a tracheostomy is in place. That's been a lot of information in a short space of time. I hope you've understood it well and enjoyed it. And we've got lots of time now to have some questions and discussions.
Thank you so much. Absolutely fantastic presentation from all 3 of our panelists, really clear, and the videos and operative steps were really brilliant. So thank you for that. We have some questions already, and I think, Gan, you may have some questions your side as well. A quick question for Hilaf. One of our participants has asked regarding the dexamethasone and adrenaline, presumably nebulizers, I think, in the conservative management of these airway obstruction cases. What kind of dosage of the drugs are we using at Birmingham?
So from the dexamethasone, the dose that we usually use is 0.2 milligrams per kilogram 3 times a day. That's the airway dose that we use. And for the adrenaline, that's 1 in 1,000. We've got the ampules of 1 milligram per 1 mil, and we usually give between 3 and 5 mils, depending on the child, and depending on the child's age and weight.
Brilliant, thank you. And slightly broader question, in terms of post-operative care, and this is maybe for you, Ms. Stevenson, or open to the panel, what rehabilitation treatments are there after surgery?
Just stop you there. You said, what rehabilitation treatments are there after surgery?
That's right, exactly. What are there rehabilitation regimens that you implement?
Absolutely. So this is within a team, and often that includes intensive care. So we've got good pediatric input, because we're not pediatricians, and we shouldn't try to be, even if we're pediatric ear, nose and throat surgeons. And then you've got your other health professionals. So we work really closely with speech and language therapists. So we're not considering just the airway, we're considering the other functions of the larynx, so the speech and the swallowing. And part of the aftercare is to improve the healing. So we focus on reflux, and certainly around a major surgery or a laryngomalacia surgery, we'd be looking to treat reflux with oral medication, and involve speech and language therapy as well. So we might have a child that needs a period of tube feeding, but we'd want to assess their swallow, is it safe, and then try and maintain their oral feeding if possible. Physiotherapy does come in terms of chest, does come into play for a patient that needs to be in intensive care. But I think our main work is to do with the feeding and the voice, and that's where speech therapy, which is a very well-developed profession here, they're experts and they're very useful and really good to work with.
That's what we've actually touched on several times in our series, is that there are only 3 speech and language therapists for the whole of Mongolia. So very interesting to hear how involved they are in your post-operative care, and to underline that point. Again, have you got some questions your side?
Of course, I have one from the audience. The question arises from the tracheal malacia issue. The question is, what about the remanagement after restenosis by the endoscopic approach for the upper airways? Yes.
So how would you manage restenosis?
How do you manage the restenosis of the upper airway after doing by endoscopic approach? Because there's some the restenosis occurs after even endoscopic dilatation, you know.
Yeah, I think this is a problem that's encountered anywhere in the world. So it does depend on the pathology. And we've got some things that we know will be treated well with an endoscopic approach. For example, a subglottic stenosis. If it's a very new stenosis and it's soft, we've got to it early rather than it going late and matured, that's going to do better with an endoscopic approach, either incising and or dilating it. But usually, I think if 3 times, if we've done a balloon dilatation, you know, fairly close together, a few weeks apart, and we haven't improved the stenosis, we need to think and stop and plan a different technique. And we have airway meetings where we put together all of our specialists to discuss our difficult cases. We talk to the respiratory physicians at the same time with that. And sometimes we need to involve other hospitals in the country and our cardiac or cardiothoracic surgeons as well. So we do use endoscopic surgery a lot, even after an open surgery. Say if we've done a laryngotracheal reconstruction, we'd need to be looking afterwards, after a few weeks, to remove any granulations, to use a balloon dilatation. So it happens after open surgery and as part of repeated endoscopic surgery. But if it's not winning after 3 times, doing the same thing, you need to stop and do something different.
Thank you. Gan, do you have any questions, any further questions your side? Otherwise, I'll ask you the questions that I ask every time.
None by now.
So what has struck you, Gan, in terms of differences in practice, perhaps between the UK and Mongolia?
For me, I don't see any differences. But the what I see from the informative presentation, I see. I'd like to mention about the medical service in the pediatric population, because the lack of instrumentation or human resource and everywhere of the country. So at least, I mean, the secondary hospital, the countryside even, they don't have the pediatric ENT surgeon also. So also they don't have any instrumentation because of that, which makes it just a one centralized pediatric service for the entire country. The kids who need some specific procedures, who they all need to go to just the capital city of the Mongolia. That's it. So that makes it more overcrowded and more overquiet situation. There's a lot more, you know, just waiting for the delayed help from the medical services. That's the issue that we're encountering currently right now.
That's what I wanted to ask you more about as well, is how developed is the pediatric ENT specialty in Mongolia? Or is it a lot of adult surgeons treating pediatric pathology, or what's the situation?
Actually, I think our pediatric field is doing very well, even they're just one centralized institute. But the problem is the overcrowded the situation for that one centralized hospital that makes the doctors more busy, and they don't have any time for self-development time. Sometimes they just the delayed information of just a contemporary management of the upper airway, for example, something like that. That's the issue, I think. On the other hand, they're doing absolutely great, I think.
So that's the Children and Maternity Hospital in Ulaanbaatar, is it? And that's your only center, really?
Yes.
Do you anything else that our panel would like to express or discuss, or any videos that you'd like to show us in the last few minutes? Otherwise, I will my closing spiel.
I've got a couple more surgical videos if they would be useful.
I think go for
Do that? Okay.
Maybe we have time for one or two.
Sure.
And please, participants, this is your last chance, do send in your questions in the last few minutes.
So this is using more technology for treating laryngeal papillomatosis. I wonder if you also see this. I think it's a worldwide problem when you have HPV infection of the upper airway and larynx, and it needs debulking to improve the airway. So one of the key instruments that we use is something called a microdebrider, a powered instrument. And this is, you can see it in use on the right here. It's got suction with it, and it can very gently debulk the disease quite precisely. It's much more efficient than using just cold steel instruments. So you see microdebriders used in sinus surgery, but there's also ones that can be used in the larynx that are smaller and gentler. I thought that might be interesting.
And you're seeing this in kids as well a lot?
In the UK, we don't see a lot of it. I'd say within our population, which is about, we cover about 4 to 6 million, we probably have about 10 active cases at any one time. So it is very rare, and we hope with vaccination in 20 or 30 years' time, we won't be seeing it. But those that we do look after have to be looked after very closely.
Thank you. Okay.
Sorry, I lost you there a second.
Can you hear me now?
Yes, we can hear you. What did you just say, Aurelian? I think we lost him.
Okay. So I think he might have asked you as well, do you see a lot of laryngeal papillomatosis?
Yes, of course we do have a lot, but yeah, I don't know exactly incidential rates about the 100,000 people in a year, but I see a lot of questions that I knew a few patients who just transferred from the pediatric hospital and performed the 77 times papillomatosis removal surgery as well, and yeah, that's quite a lot. There's quite new to us to using the microdebrider for laryngeal papillomatosis. We just saw it from the textbooks or something, or just the technological companies. And yes, it was highly effective to removing, but we don't know the exact result after post-op healing, such as the rescoring or just any another adjacent therapy, including just a steroid stenting or something like that. After, is there also some stenosis occurring after removal by the microdebrider, something like that? How often do you use the microdebrider in laryngeal papillomatosis?
So I think if there's bulky disease, we would always use it. I think if it's very limited disease, then I would just use normal instruments. It's not worth the cost and to open an instrument like that. You know, even though we're very lucky to have a lot of resources, we need to be sensible with them. But the interval between surgeries depends on the child's disease. As you know, you can get to 50, 100 surgeries if the disease has a long course. And, you know, talking about other treatments for papillomatosis is a lecture on its own. But sometimes bad disease is coming every month, up to every 3 months. And the microdebrider works well, but obviously it is a powerful tool that needs to be used carefully, like any technology.
Thanks.
Sorry, you lost me. Thank you. So we're coming to the close now of the webinar. Thank you so much to our 3 panelists, Miss Timms, Miss Stevenson, Mr. Peled. Absolutely fantastic talk. Thank you for joining us, all of you, along the whole course of the series. I hope it was useful to you. So this is the QR code for the online form. It's key for us to improve for future series. And also we're collecting emails through the form. If you leave us your email, we will contact you over the next month or so to be part of a piece of research. So if you'd like to be included in that and collaborate with us and have your name as part of the collaborative group on the paper, then please do fill out the form. That's our only way to get through to you, because participation and questions have been anonymous. Gan, do you want to maybe quickly translate that in Mongolian?
Of course I do. And first of all, I'd like to imply my gratitude to all the speakers and the panelists who's spending the valuable time to inform some innovative information to us, and I'd like to thank all of you. And хүмүүст өнөөдрийн сургалтанд оролцож байгаа хүмүүст өнөөдрийн сургалт маань хамгийн сүүлийн сургалт байсан байгаа. За тэгээд энэхүү сургалттай холбоотой survey form-ыг бүгд QR code юм байна. За энийг яг одоо утастай камерыг гаргаж байгаа survey form-а бүглэстэ. За гэхдээ бид нөгөө сургалт дууснаас хойш 1 сарын хугацаанд ерөнхийдөө надад дамжуулаад ч юм уу та бүхний нөгөө ирүүлсэн мэйлийн дагуу зөрүүлээд харилцаад нээлттэй байгаа. Тэг өмнөдөө холбоотой янз бүрийн санал хүсэлтийг болон тэр мэйлээрээ эргүүлж аавна гэсэн бодолтой байгаа. Тэгэхээр үүнтэй холбоотой нэмэлт хэлэх зүйл, сануулгах зүйл, ямар нэгэн хүсэх зүйл байвал мэйлээр дамжуулаад харилцаж болно.
Thank you, Gan. Thank you, Ms. Stapleton, and the whole ENT UK Global Health Committee who have made any of this possible. Thank you to our participants, and hopefully we can repeat this kind of educational intervention. Bayarla.
Bayarla. Hope you see you again.
Thank you, Bayarla.
Bye-bye. Thank you very much.
Thank you.